So younger patients had the greatest benefit from the blinatumomab, but older patients also showed improved outcomes. How do you individualize therapy for older adults with ALL, particularly regarding immunotherapy and asparaginase use?
Good question. So from what we know now, and remember E1910, the 10 in E1910 meant the study was approved in 2010. We didn't start enrolling patients till 2013. But what we know now is that probably the E1910 chemotherapy is not ideal for older patients. And I mentioned earlier that there's been some studies where we've used immunotherapy alone. So I think for an older patient, I'm not necessarily sure that I would automatically treat them with the E1910 regimen. There are some studies looking at either low dose chemotherapy, or there was one study I mentioned where no chemotherapy was given. So I think the approach in older patients is going to be to rely more on immunotherapy, either without chemotherapy or using low doses of chemotherapy.
Mm. So I want to switch and kind of talk a little bit about translating research to practice. Given that clinical trial populations differ from the broader patient population, what advice do you have for clinicians when applying findings such as those from E1910 to patients with comorbidities, um, or those not meeting strict eligibility criteria? We discussed this a little bit, but are there any kind of areas in that question that we haven't touched on yet?
Well, I think that what that really tells me is that treatment needs to be individualized, and every patient's a little bit different. So I think that immunotherapy is become and has become an important component of the treatment of ALL, and I think it should be incorporated into the treatment. I think dealing with the older patient or the patient with comorbidities, the bigger challenge is what to do with the chemotherapy and whether to go with lower doses of chemotherapy, shorter duration, and that's where I think things have to be
Mm.
individualized. So that would be my advice to clinicians would be to try to maintain the immunotherapy as much as possible, and then modify the chemotherapy as needed to minimize side effects and maximize benefit.